All right. Hi, everyone. Thank you so much for attending CMS's Health Equity Conference. This breakout group will be about community-powered health, igniting change through engagement and community-led solutions. I will be your moderator today. My name is Aaron Plotke, and I'm a senior policy analyst at Families USA. We are a leading national nonpartisan voice for healthcare consumers, and we are dedicated to achieving a high-quality, affordable, and equitable healthcare and improved health for all. And regarding my appearance, I'm a white male, brown hair, a little messy, blue blazer, white button-down shirt, brown pants. I'm very excited to introduce our wonderful panel of speakers who are going to present their work as it relates to our prompt, Igniting Change Through Engagement and Community-Led Solutions. But before we get started, a few housekeeping items. This session is an hour long, between 1:55 and 2:55 p.m., and I'm going to make quick transitions between each of the presentations. Unfortunately, we won't have any time for questions during the session as we have a lot of exciting material to cover, but we do invite folks to meet with any of the presenters after the session and pose questions at that time. And if we do end a little early, we will do a ad hoc auditing of the program and we'll allow for some questions. So let's dive in. Our first presentation will be from Melissa Fox and Dr. Melissa Clark on the important role of community-led solutions in reducing health disparities. Melissa Fox has had a distinguished career of over 20 years leading innovations in healthcare operations, including federally qualified health centers, behavioral health, home care, and hospice. Melissa has been featured as an expert speaker for her work within diverse healthcare environments and addressing the importance of utilizing innovations and community-based collaborations to reduce health disparities. In her current role as Chief Operating Officer at Ascenda Integrated Health, Fox oversees operations for over 100 programs throughout 12 counties in New Jersey. And Fox has served as an expert speaker for various national organizations, is a board member of several nonprofits, and also serves on the Healthy New Jersey 2030 Advisory Council. Our second Melissa, Dr. Melissa Clark, a seasoned emergency medicine physician, is a pioneering leader in population health who has worked for Fortune 100 companies, health systems, and academia. She's passionate about empowering individuals to be their own best health advocates, and she's been a leading voice regarding health equity for vulnerable populations. Her company, the BHE Group, creates and deploys strategies to achieve health equity centered in addressing health literacy, patient and community engagement, and advocacy. She's a published author, advocate, media contributor, and keynote speaker on matters of healthcare quality, payment reform, and health literacy. And so without further ado, please give Melissa Fox and Dr. Melissa Clark a warm welcome.
Good afternoon, and thank you, everyone. First, again, I'm Melissa Fox. My pronouns are she, her, and hers. I am an African-American woman of average height, maroon blazer, and long braids with highlights in them. There's highlights in them today. So all of us are here today because it's become abundantly clear that it's time for a change. A 2021 Yale survey revealed that after 2 decades of increased healthcare spending, investments in addressing health inequity, and good intentions, there's been little to no progress in eliminating racial, economic, and ethnic disparities. This means that individuals, families, communities across our country continue to bear an unfair burden of poor health outcomes, which not only affect their physical, mental, and economic wellness, but also has generational implications. We propose that the input and participation of the communities most affected in their own healthcare delivery, access, and engagement needs to be intentional, prioritized, and sustainable. So I'm sure many of you are familiar with the community health worker role and its proven effectiveness in improving health outcomes. Because these individuals share a community lived experience and authentic connection with those they are supporting, the multifaceted positive impact is significant. However, these roles tend to receive limited funding and are primarily engaged as ancillary to care. Today, we will present a model for consideration that proposes to shift the existing paradigm. But first, Dr. Clark will share more information on the Choose Healthy Life program, which is an excellent example of the power of the community health worker role.
Good afternoon, everyone. My name is Dr. Melissa Clark. I'm a Black woman, average height, curly fro, big smile because I've returned to the Mecca Howard University where I started my career as an emergency medicine physician. So Choose Healthy Life is an organization. It's rooted in the Black church and as such is part of the fabric of the African-American community and is afforded a high level of a valuable community, a valuable commodity rather, which is trust. It harnesses the resilience of our communities to address health inequities. Choose Healthy Life was born out of the need to mobilize rapidly in the early days of the COVID-19 pandemic because of the overwhelming number of funerals that were being performed in the Black church. So Choose Healthy Life created a network of 60 faith institutions across the country, which actually expanded to 120 faith institutions across 13 states under a 2021 HRSA grant. It deploys community health workers known as health navigators, drawn from the ranks of the faith institutions, and they serve the community by promoting COVID mitigation strategies, which include testing as well as vaccination, and data gathering on social determinants of health and closing those gaps through collaborations and partnerships with other local community-based organizations. So the current slide illustrates the link between faith, science, and community that's inherent in the Choose Healthy Life model. There's a clergy advisory council, which you see in the top left of the slide. There are ministers from around the nation, noted as community and policy leaders in their own right. There's a medical advisory board composed of distinguished public health and medical leaders, and a variety of community and corporate partners invested in magnifying the work of these 120 churches that you see listed on the bottom right. But the centerpiece of the work is really the groundwork that's being carried out by the health navigators. They are analogous to community health workers that Melissa first mentioned, in that they're community members, they're culturally fluent, and they're invested in the well-being of the community members that they serve. They have a full-time, this is a full-time position, and they're paid as such. They undergo a rigorous training process by my company, which is the Be Health Empowered Group, which is a health literacy company, using an evidence-based curriculum developed around the 11 core competencies of Choose Health, of community health workers identified in the Community Health Worker Core Consensus C3 project. With the acute phase of the pandemic winding down now, the Choose Healthy Life health navigators have expanded to wellness promotion and addressing other diseases like obesity and diabetes, which is what put the Black community and other communities at risk for the worst outcomes during the pandemic in the first place. And they now deploy a program called the Blueprint for Wellness, which was started just this past fall. It's a program in conjunction with Quest Labs that makes screening, lab, and biometric measurement testing available free of charge at community events to screen for chronic diseases. And what the health navigators do is familiarize people with the program and then connect people to care once their lab results and biometric screening results are available. I'd like to share some results to date. The first 2 years of the Choose Healthy Life program, during the pandemic, there were 3,700 events in targeted communities with over 23 million educational touch points, either virtually or in person, resulting in over 110,000 people either being tested or vaccinated. And then since launching the Blueprint for Wellness, the first 180 days of that, which started last fall, over 6,000 people have received the screenings and lab measurements. And of note, the health navigators are not employed by a healthcare organization. Part of their success has been staying in the context of a trusted community organization with that longstanding trust that I mentioned. And that's been what has persuaded thousands of people to roll up their sleeves, take their first vaccine for COVID-19, as well as allow blood draws to be taken and to be connected to care. And this success is based on the trust that led the former CDC Director Walensky to say that this community-led model is one that can address health disparities beyond the pandemic, which is exactly what we're doing.
So as you heard from Dr. Clark, what we're talking about here is a model that is proven, it's absolutely effective, and it's cost effective in many ways, as well as contributing to significantly better outcomes. So what are we talking about here today? We're proposing that there is a model that has a three-pronged approach. The model essentially will include three parts. The first part is to engage community health workers as leaders, not ancillary, but as leaders in the care paradigm within their communities. This means that they're engaged at the forefront, that as you heard from previous presenters, that their opinions matter and their opinions actually figure into the implementation of the care model. The second key component is to ensure that there are enough providers within the identified area to provide the care required. There are too many areas across this country where there aren't enough providers that accept Medicaid patients, which means that as we are providing better access, as we are providing better opportunities and even education related to achieving care, if there's not someone there to provide the care, of course, then it's falling on empty promises. The third area is to ensure that there's an implementation of the CMS-defined accountability measures. How then are we holding ourselves and the system accountable to achieving the outcomes that these communities need and deserve? So this three-pronged approach engages what you heard Dr. Clark mention in terms of the community-led approach, where community health workers are leaders and not ancillary, that they're fully sustained and sustainable in terms of how they are being reimbursed for their time and how community-based organizations are supported in these payment models, ensuring that there are providers who are there and able to take care, even if that means providing additional reimbursement and incentives similar to other clinical care models that support underserved populations, and then implementing the accountability measures so it's clear that the outcomes are being met. Now, the key thing about this, of course, for this potential pilot is that to ensure that we are utilizing a population health approach, that is targeted and customized according to the needs of the communities. We also want to have a closed loop program that includes a pilot that's engaging all of the community members. And then we're implementing secure data aggregation. I'm going to go ahead and pass it to Dr. Clark so she can close us out here.
The key to much of this, as Melissa mentioned, is provider availability. Although Medicaid has been a lifesaver for many who have no access to insurance, the reimbursement discrepancies embedded in the program establish a two-tiered system of care that reinforce healthcare access issues and quality of care gaps. A MACPAC analysis highlighted that physicians are less likely to accept into care patients with Medicaid versus other types of insurances. And you see the statistics there on the screen, with discrepancies being greatest in the 5 states listed. So having an experienced and structured community-based organization as a lead that allows community health workers to leverage trust and cultural fluency to influence consumer health choices is key. That will get us closer to aligning to this quote from Dr. Alice Adams, which describes that in order to root out inequities and bias in healthcare delivery, we have to fundamentally change the power dynamics and system issues which perpetuate those inequities. Thank you very much, and this is how you can contact each of us.
Great, thank you both. Our second presentation will be from Desiree Collins Bradley and Dr. Neelam Agarwal on community engagement and stroke preparedness before and during COVID-19, the road to public policy. Mrs. Desiree Collins Bradley is a resident of Houston, Texas. Her passion is patient and family engagement in healthcare and ensuring that the patient's voices are represented at all levels of healthcare quality improvement. Her daughter's medical journey has inspired Desiree to become an advocate for the medical community. Her goal is to spread the ideals of the importance of the patient's voice, not only being heard, but included in the healthcare quality improvement process. She currently manages a very diverse patient network, PPIC, or otherwise Patient Partner Innovation Community. She aims to inspire patients to become active in their health systems. Dr. Neelam Agarwal is a faculty member of the Rush Alzheimer's Disease Center and professor in the Department of Neurological Sciences at Rush University Medical Center. She has multiple roles within the center that include serving as a principal investigator and site principal investigator for a National Institute on Aging funded clinical trials and longitudinal population-based studies. Her research focuses on the impact of cardiovascular disease and stroke and disparities to cognitive decline and dementia in Chicago's racially diverse communities, and is the PI for the Mediterranean DASH intervention for neurodegenerative delay diet in stroke patients. Mouthful. She was an MPI for the PCORI-funded SIRIUS study, which laid the foundation for the 2 SIRIUS study that examined neighborhood barriers in seeking acute stroke care during COVID. Please give Mrs. Desiree Collins Bradley and Dr. Neelam Agarwal a warm welcome.
Well, thank you. Oh boy, was I smiling when I heard your presentation, because the previous presentation he just hit it one after the other about community engagement. So you're going to get the message again, but it's going to be on a different topic. So I am a female, I'm a mixed race female. I'm trained as a cognitive neurologist, but I've been very lucky to be involved in epidemiology studies that put me in the field. So when I say the field, I mean community. And when I say the field, I mean doing home visits. I've done over 2,500 of them in Chicago in the homes. I've seen disparities, I've heard lived experiences, and this is how basically this project we're going to talk about came to be. But what I also learned when I was in the field as the doc is that I need to reach out to other organizations and partner to get the work done what we had to do. And it was very evident that this is not going to happen within the construct of an academic institution. So I went to community partners, and here I partnered with Dr. Natasha Washington from ATW Health Solutions and her team with Ms. Bradley, and the rest of the team members are here. That partnership allowed for what I'm going to talk to you about today, the SIRIUS study. If it was not for that partnership, we would have not had the results that we were able to obtain, and we would have not been able to really keep this project going in multiple iterations. So let's step back a little bit. What is SIRIUS? So I'm going to give you the backdrop of what happened with me. In my experience, I was in the home seeing people in our population studies that we conduct 10 to 15 years. We follow people every year to see how they age, 65 and older. I was seeing people having stroke with my people, and I'd be asking them about stroke. What happened? How did it happen? And a couple key things kept coming up. Delay in response of activating EMS, delay in coming to the ER, not receiving TPA. My ER doc is nodding her head up here because she knows it, not coming in, calling the daughter, calling the son, calling everybody except EMS to come in. And what was heartbreaking for me as a physician and a neurologist was to know that down the street is a primary stroke center that is equipped to handle these issues. So the question was, what is going on? Why are people not activating the acute system to get you for stroke? Why isn't it being heard as an emergency? What do we need to do to handle that? And that is how SIRIUS was born. We were getting serious about stroke to activate people to understand it's an emergency. Here's what you can do, but also to understand the barriers of why people were not accessing this. One of the key things that came through, and this came through working with our community partners and Dr. Washington, the messaging has to be clear and it has to be simple. The message was call 911. That was the message. And so we took that to heart and we put this program together. We put a PCORI funded grant that was totally funded for 2 years with this disparities grant. And we conducted it in Chicago, really making it that people understand you have to call 911 for stroke. Your life depends on it. Your outcomes depend on it, and it will lessen the disparities. Now, one of the things that comes with community-based projects is how do you measure change? We all have that. What's the metric? What is the metric? Now in stroke, because things are connected so well, you can either say the calls to the emergency EMS system, you can track that. You can track how many people come into the hospitals. You can track how much TPA is being given. What we wanted to know was the EMS system, could it be activated? And here I just want to show you what we were using back in 2014, 2015. We were already doing this geocoding. We were already looking at EMS calls. And on one side, you can see where the circles are is showing red and orange. That means there were increased EMS calls coming from the neighborhoods in Chicago that we know had the highest stroke rates and the highest death rates from stroke. Both things were going on here on the south side. And so we could see, if you just look over, the areas before that didn't have any activation. So we were able to show that we could have change affected by our intervention. That was very powerful. The community could see that, and then that translated that the calls were coming in and EMS was being engaged. So that's the backdrop for the SIRIUS study. I'm going to hand it over to Desiree right now to talk about how we furthered that study, because we all know what happened. COVID hit.
Thank you. Thank you, Dr. Agarwal. So Dr. Agarwal set the framework of the why we were doing this. And I'm going to kind of dig a little bit deep as quickly as I can about the how. So how do we achieve this? We engaged, we call them stroke promoters. So in the first iteration of SIRIUS, we had a couple hundred stroke promoters, and these are community partners. I'm talking pastors, beauticians, fitness instructors, everyday people that are in their community, because they knew how to translate that clinical information into terms that their community could then take and then spread long term. So if you look at the engagement principles, and I won't go into all of the details of our engagement principles, there's two particular highlights that I want to highlight here, and that's community ownership. That goes back to, you all seen the PAC to Act Fast. You've seen the American Heart Association put that out there. But what we heard from our community partners is that, well, this really doesn't resonate with us. These images don't look like us. And so when we receive that feedback, we then alter that image in infographic to really include persons that look like them. And then going into that experiential model, that Kolbe model, we're constantly learning from those lived experiences, because we all live in our own prospective places, right? But you know what your community needs, and we're constantly learning and growing together. So we didn't just use these principles for Too Serious and Serious. This is what we use across ATW. This is kind of like our guiding force as we move forward. And then the other part I want to do to hit on before I move a little forward, and I'll put these pictures up there so you guys can see. This is our community partners and our research team, our clinical team in action in the field, in nightclubs, in your community centers. We took that messaging, actually boots on the ground. You got to meet the people where they are, right? So this was Rapid Cycle. So we did Rapid Cycle. So first SIRIUS, and I'll go to the next slide. So first SIRIUS was about not over 2 years, but 9-month study in terms of stroke promoters activated into the field. And then what happened? COVID happened. So COVID happened, and there was a direct correlation early on between strokes and COVID-19 and recovery. People were still having strokes, but what was the messaging? Stay home, hunker in place, stay home, right? So here we are then, okay, as a team, we're like, you know what? What can we do with our first SIRIUS and take this to a virtual environment? We still need to get the message out, despite not being able to convene like we are here today. So we re-engaged our stroke promoters, and we took that 2-year kind of 9-month activation and really brought that down to a 90-day campaign. And I want to stress to you here to understand that, yes, this engagement model that we've created can be applied in other areas, right? So you can take the long-term approach like we did with SIRIUS, or you can take it down and reduce it to a rapid cycle improvement, right? So just think about that. And I know I'm looking at my timekeeper. So lessons learned, I'll kind of speed through this as quickly as I can. One of the things I want to highlight here is 40,000 pledges we received. Our stroke promoters hit the ground running. Some listened to us and went that virtual route as in response to COVID-19. And we had one that said, you know what, 81 years old. She came back and she said, Desiree, you know, I'm not really getting this social media thing. I'm going back to the old way that I know what to do in terms of picking up that phone, calling, phone banking, still spreading the message of stroke awareness. And I'll tell you, she was one of the most successful stroke promoters that we had. It reiterated that importance of that connection piece, engagement piece. Okay, thank you, timekeeper. So I'll get to our main point. Thank you, thank you. So driving policy. So here we are in 2023, but I want to go back. So one of our stroke promoters, Dr. Tanya Robinson, you know, ATW did this tremendous amount of work. We had these published results in partnership with our clinical partners, our health systems team. She came back and said, you know what? We need to write legislature around making sure that it is mandated to have stroke education awareness in law and provide funding to support that. And we are proud to say that in July of 2022, that bill was signed into law. Yeah, clap that up. That deserves it. So I say all that to say here, and I'll go to the next slide because I want to say, I know we didn't get to unpack all the details, but we do have publications around our studies. So I urge you to go to our website. We have a publication that's hot off the press that will be uploaded to our website soon, but connect with us and we can disseminate the information that you need. But I want to leave you with a sense of urgency into action in my last 30 seconds. Think about this engagement model that we've created. How can you apply that to other areas? Diabetes, behavioral health, behavior illnesses. What can we do to really take that model and duplicate it? We just don't want this here at ATW and stroke. We want to see laws in all your states that you live in, mandating put your money where your mouth is to make sure that people are not dying unnecessarily. So I'm going to stop there. But again, thank you. And off to the moderator. Where are you? There you are. Okay. All right.
Thank you.
I tried to say.
Thank you so much. And for staying on time, of course. So our third presentation is from Katie Ettman and Erica Hansen on building capacity in healthcare, partnering with communities to address social determinants of health. Katie Ettman is the Food and Agriculture Senior Policy Manager with SPUR, or the San Francisco Bay Area Planning and Urban Research Association, where she supports efforts to create a Bay Area where everyone has enough food to lead a healthy life, where we produce food in a way that supports both the environment and an equitable economy. In addition, she serves on both the Foodwise Education Committee and the San Francisco Market Strategy Committee. Prior to joining SPUR, she worked with the Food Bank of the Rockies in Denver, Colorado, managing the procurement of fruits and vegetables for 30 counties in Colorado and the state of Wyoming. Katie earned her Master's of Public Administration from the University of Colorado, Denver, and a bachelor's degree in Public Communication and Community and International Development from the University of Vermont. Erica Hansen is a clinical instructor and attorney at the Center for Health Law and Policy Innovation of Harvard Law School, where she concentrates on policy to address the social determinants of health, improve health equity, and mitigate health disparities with a focus on the needs of low-income people living with chronic conditions. She has a particularly active portfolio dedicated to the integration of health-related social needs into healthcare delivery and financing at the state level. Please give our next speakers a warm welcome.
Good afternoon, y'all. Katie Ettman. For those who can't see me, I am a slightly taller than average woman, wearing what some might describe as a very electric blue suit. So excited to be with you all today. And we're going to be talking a little bit about some work that's been happening in California as it relates to the social determinants of health. But we have to start with some base setting. So in California, we rename everything. It's just what we do. So we call Medicaid Medi-Cal, and we have an 1115 and 1915B comprehensive waiver. And so for those of you who aren't familiar, waivers allow you to make exceptions to federal Medicaid rules and test and pilot new things. Some of you in the room could write an entire paper about it. I know the basics. But like I said, we rename things. And so we have called our waiver in California CalAIM, California Advancing and Innovating Medi-Cal. And as part of that waiver, we have used a statutory regulation known as in lieu of services to cover social needs. And so what that looks like is you are looking for cost-effective alternatives to standard Medicaid benefits. And so in California, we renamed it again. And so we call in lieu of services community supports. And so that's actually a menu of 14 different services ranging from housing, transportation, and then what I'm going to be digging into today with my colleague Erica is what we call medically supportive food and nutrition interventions. And so you're like, what the heck is medically supportive food and nutrition? So this is a term that we're using in California to talk about a spectrum of food-based services, with the idea that we want our healthcare professionals to be able to match the acuity of a patient's condition to the intensity of the intervention that they require. We don't want to be giving a patient who needs a medically tailored meal just a grocery box if they can't cook for themselves, for example. And you will see on the diagram, we divide these up into two categories. On one side, we have meals. Lots of people are familiar with medically tailored meals, an RDN, tailoring a meal to an individual, and they're often delivered to someone's home, say after they've left the hospital, or maybe they're dealing with a really intense diagnosis like a renal condition. We also have medically supportive meals, same idea, except it's not necessarily tailored to the individual and might not require an RDN. Then on the grocery side of the house, medically tailored groceries, same idea, RDN involvement. Medically supportive groceries, we think of those as generally healthy groceries to support someone. Food pharmacies, which we've really talked about, is typically the co-location of food in a healthcare setting. So imagine a pop-up farmer's market at your health clinic or hospital. And then produce prescriptions. So giving someone a card or voucher so they can go out into a retail environment and buy their own free fruits and vegetables. And what you'll note at the bottom is these sort of nutrition wraparound supports, the idea that we want to amplify the effects of the food when we are providing them to patients. And the reason I talk about this spectrum is interventions, like I said, is matching that patient and the actual intervention, but it's also making sure that these are going to be accessible in different communities across California. About 15 million Californians are on Medicaid, and we want to make sure that we are going to be able to get those in our rural areas and in our urban areas and everywhere in between. And so these interventions have now been live for about 18 months, and I'm excited to introduce my colleague Erica to talk about some of the lessons learned from our community supports implementation.
Thank you so much, Katie. For those of you that can't see me, I am a female of mixed race and I am wearing a pink pantsuit. I swear that we did not coordinate this. We just showed up this morning kind of in these matching pantsuits. So to kind of zoom out a little bit to give some context, because I know a lot of people in the audience might be thinking like, oh, this is just a California thing, and I'm going to kind of zone out. And I know we have a lot of people on Zoom from all 50 states and all of the territories. This is really part of a groundswell of state action. This is not just a California thing, and this is also not just a food thing. So you've heard a lot about the White House Conference on Hunger, Nutrition, and Health. And as part of that conference, the Biden and Harris administration endorsed the use of 1115 waivers and other flexibilities to cover health-related social needs, including nutrition supports like the medically supportive food and nutrition supports that Katie just went through. So here on the screen, you can see all of these states have current approved or pending waivers to cover nutrition supports. So this really is a growing body of policy levers where states are trying to leverage this federal policy endorsement. And it really ranges from Arkansas, who's trying to use this policy lever to endorse nutrition education, all the way to kind of the groundbreaking work that California is doing with all of this coverage. And I'll say that California, if you went to the earlier state presentation, right, is covering these nutrition supports as well as 14 community supports that include things like housing and, very relevant to what we're going through right now, asthma remediation, right? And then there's other states like North Carolina that are doing very similar things, right? So not just a California thing, not just a food thing, very relevant and important. And so these lessons from our case studies in California are kind of applicable across the board. So what we did in California is we interviewed CBOs and managed care plans that have been implementing these programs over the past 18 months to find out, what are the successes, the potentials, and really the pain points, right? So if you've gone to some of these really breakout sessions and some of the keynote speakers, you've learned this is a journey and it's challenging, right? CBOs have not been integrated into healthcare. And there are a lot of difficulties and there is a lot of adjustments that we need to make. And this is really an opportunity to change healthcare for the better, right? We know that healthcare has not been equitable. That's why we're all here. And so it would be a real missed opportunity if we just integrated CBOs, if we just integrated these services into healthcare without changing things that weren't working, right? So I really do want to emphasize the successes and the potentials, but I also want to emphasize the challenges and the things that need to be tweaked. So I should have actually switched these and said early successes and challenges based on the way I structured this slide. But 4 things to emphasize on the early successes and potentials of the community supports program in California and really all of these programs throughout the country. Service access. So this is an opportunity for statewide access to these medically supportive food nutrition services and these other health-related social needs services. Whereas before, these services were located based on where grant funding was located and where these CBOs were located. This is the opportunity and the potential, and we're starting to see this happen of we can have statewide access to these services in rural communities, in underserved communities. We're able to see the impact of sustainable funding, right? That people can actually have access and confidence that they will have access to these services. Providers are saying, thank you, right? I don't just have to screen for these services. I can actually give a referral and have confidence that my patient is actually going to get a produce prescription. They're going to get produce in their home, right? And it's giving confidence in those screening and referral services as well. And equity, right? So all of this is about equity, but it's important to actually call that out and center it, right? What are we doing to actually make sure we're reaching those rural and underserved communities? California is a huge state. We often think of only the urban centers, but there are really, really diverse areas of the state. There's a lot of Native populations in the state of California. So we need to think about like, what is the potential to reach those areas and those populations? And then finally, research value and return on investment. This is ultimately a payment system, right? We're paying through Medicaid. We know that ultimately these services save money and save utilization. And we're studying that through this. On the right-hand side, we have some of the challenges that can undermine these potential successes. And we really need to address those and think about how can we rearrange our healthcare system to address things like low reimbursement rates in Medicaid, right? If we're not paying our CBOs enough money so they can serve those rural areas, we're still going to replicate the broken system that we have here. Eligibility criteria. If we're defining eligibility criteria so narrowly that we're only serving people who are already going to the doctor, we're going to replicate those same problems. And then there's a lot of infrastructure building that needs to happen. If you went to the state panel earlier, you heard about the billions of dollars that California and the federal government is putting in to this program to actually build that infrastructure in CBOs from the ground up. So I suggest that you read our case studies. I'm getting cut off, but Katie is going to talk about where do we go next.
And this will be really quick, which is right now our Medicaid waiver, it's time limited. They're generally for 5 years. and that's not enough. It is also an opt-in service. So not every managed care plan has to cover all 14 community supports. And so I was lucky enough to co-sponsor a bill to make these into full covered Medicaid benefits in California. I will say, unfortunately, it has died in appropriations because it's often about the money, but that does not mean that we will quit. We plan to continue and to reintroduce legislation to make sure that we make these accessible to everyone in California so they're not reintroducing those same injustices. So thank you all so much. This is our contact information.
Thank you both. So for our fourth presentation, Lynn Mertz and Teresa Edelstein on the LEAD Collaborative Takes on Health Disparities Together. Lynn Mertz is a senior strategic policy advisor for the Global Thought Leadership Team at AARP. Her portfolio addresses health disparities across the lifespan, in particular the 50+. And prior to joining this team, she was with the Center to Champion Nursing in America, an initiative of the AARP Foundation, AARP, and the Robert Wood Johnson Foundation to improve America's health through nursing, where she focused on nursing education, population health, and managing the Nursing Innovations Fund. She holds a bachelor's degree from Drew University, a Master of Urban Planning degree from NYU's Wagner School, and a PhD in higher education policy from Seton Hall University. Ms. Edelstein is a senior vice president of the Center for Partnerships Transforming Health at the New Jersey Hospital Association. She directs the policy, regulatory, education, and advocacy work related to post-acute care, long-term care, and managed care and insurance issues. In addition, she oversees NJHA's emergency management team. Teresa is a part-time faculty member at the Edward J. Blaustein School of Planning and Public Policy at Rutgers University. She earned her master's in public health at the Columbia University Mailman School of Public Health and has a Bachelor of Science degree from Georgetown University. Please give our next speakers a warm welcome.
Good afternoon, and thank you everybody for coming and staying with us for the presentation today. My name is Lynn Mertz. I use the pronouns she and her, and I am, for those who wanted, wearing a blue plaid jacket and a white top, and I've had what I refer to as my pandemic platinum hair since March of 2020. So I am happy to be with you all, and I'm really loving everything that I've heard earlier today with the sessions in this particular panel and the exciting work that's going on. So thank you. So we had so much that we wanted to say. We sort of created our slide deck a little bit so that it was more informational for you than going one at a time. So I might bounce around a little bit, but we wanted to have our time to tell a little bit more of our story. So a little bit first about a little family photos here. You can see myself and Teresa. We wanted to highlight a couple of our LEAD collaborative partners that I'll explain in a moment, and they weren't all able to join us today. So I just wanted to acknowledge Aya Schumann and Cheryl Garland, who are also part of our team. The core leadership team for the LEAD collaborative is made up of Malik Joshi, Deneen Richmond, myself, and R.T. Varanasi. And who is this LEAD group that I've been telling you about? So LEAD stands for Leaders in Equity and Diversity. We are a collaborative that was the brainchild of Dr. Malik Joshi and Jean Axios, who was formerly with AARP. And what they wanted to be able to do is bring a group of healthcare and community-based organizations together to try to take on health disparities. This is focused on the Mid-Atlantic region. So from New Jersey at the north down to Virginia on the south, we have about 7 states in the district represented. Our goal was to get about 20 organizations to join us and to be on this journey. And we can fortunately say that we have over about 34 organizations about health. Half of them are health centers and the other half are other health and community clinics and community-based organizations, all with the common goal of addressing and aspiring for health equity. Let's see what and this is our kind of proud banner. We've gone from people to logos on this one to see all the 34 organizations. I did a little spotlight on Chase Brexton, which is where Aya was, and VCU Health where Cheryl is. So you can learn a little bit more about them later. And for ARP, this is important to us because our goal is really to be able to ensure that everybody can live the life they want as they age. Before I go on to Teresa, I just want to explain a little bit again about the LEAD collaborative. As I said, we've all come together to address health equity. We've done it by each organization committing to take on one of three goals. Either they are going to work on diversifying their leadership or governance structure, they're going to take on a disparity in care, or they're going to address one of the social determinants of health, or they might do a little bit of all three of those. But over the next 18 months together, they're working individually as well as collectively on these different cares so that we can try to begin to make impact and to also kind of recognize that we're not in this on our own, that, it's part of an ecosystem that we're trying to build. We come together on a regular basis. We've met twice in person, which is no minor feat for everybody having to come together. And then we backfill it with webinars, just about on a monthly basis for best practice webinars. We're trying to, as I said, we're trying to build a community, and I can see that happening as the different organizations are also reaching out to each other and learning from what each one is doing along the way. I think what I've really observed so far and what's really struck me is the impact that this is having on leadership. So you have, the 18 organizations. It's not necessarily senior leadership who is doing the work in this, and it might be somebody else along the, within the organization. But we are beginning to see, and I think Teresa will share a little bit more about it, is the fact that somebody in their organization is participating and taking on whatever the particular issue is that they want, that it's now on the radar, it's on the mindset of the senior leadership there, and further changes happening. So it's that ripple effect about the power of kind of taking that first step, and it might, for some it's the first, for others it's the 10th, but it doesn't matter. They're making a broader impact along the way. They also feel that they're not alone, which has been really important for us. And I just wanted to, before I pass it on to Teresa, just share this one quote that somebody just happened to mention in an email to us, is that participating on the LEAD collaborative has been very valuable in terms of making this initiative a priority for our organization and then sharing some of the information from the sessions with our executive leadership. So right out of the mouths, we've heard it there. So thank you. And at this point, I'll turn it over to Teresa.
Thank you, Lynn. I'm Teresa Edelstein. I'm a white woman of very small stature, so I had to adjust the microphone. My pronouns are she, her, and it's really great to be with all of you. Thank you for sticking with us this afternoon. And to all of you on Zoom or virtually, thank you for being here. So let me start with just a little bit about who NJHA is, New Jersey Hospital Association. We're a trade association with over 400 members representing acute care, hence the name Hospital Association, but also more than 200 post-acute providers, behavioral health providers, schools of nursing, other educational institutions, really a wide array of organizations. And one of the key reasons at a very high level that we decided to join the LEAD collaborative and facilitate a group of New Jersey providers was because what LEAD stood for is so closely aligned with NJHA's stated mission, which is to improve the health of the people of New Jersey. It's that simple and that complex, all in one sentence. On the slide, you can see our 4 participating organizations. Bergen Newbridge Medical Center, which is a large acute care and behavioral health provider. They also have a 500+ bed nursing home on their campus, plus a whole array of outpatient behavioral health services. Jewish Home Family is a senior living provider with a campus that includes assisted living, outpatient services, skilled nursing, and a shelter for people, older people who have suffered abuse. Kessler Institute for Rehabilitation is a select medical company. It's an inpatient rehabilitation hospital with 4 locations currently in New Jersey. And with Kessler, we're working primarily with their outpatient services. And Spring Point Senior Living is a senior services provider. They have independent, affordable senior housing as well as continuing care retirement communities throughout the state. And the aim that these 4 organizations came up with together when we were in Maryland back last November was to increase partnerships and use those partnerships and other methods to improve or increase access by 20% to mental health services, outpatient rehab services, and primary care primarily for older adults. So before I dig into some more of the slides, which are really intended to just give you a flavor of what our organizations are up to, I want to just say that the organizations have really been working hard to shed old habits. It's very typical of provider organizations of every kind to go out into the community and say, this is what we have. You should come use what we have. And instead to flip the script and go out and listen to what people say they are struggling with, they want, they're lacking, their need, and also get to those organizations. And every one of the presenters today here and in other sessions have talked about those places where people go or where they gather. The beauty salon, the barber shop, the library, and for older adults, the senior center, the grocery store, that's where people go. And so we need to be connected to those organizations. And as so many of you have said, leverage their voice, leverage their knowledge, leverage their connection to the community. We don't have to do it by ourselves. So that's been something new for healthcare providers. We tend to think as healthcare providers that we have the answer already, but we don't always. And the other piece is building trust. And you've all talked about that today. Trust is at the foundation of making change. There's no doubt about that. So I've talked a little bit already about why we joined the LEAD Collaborative, but I think it's very important to think about this as far as there being creative approaches, new ways of thinking about how we collaborate, addressing health-related social factors with improved access and outcomes, and really tackling something I haven't heard too much about today, which is ageism. In addition to all of the other disparities and inequities of populations throughout our country, once you looking older like me, people tend to look at you a little bit differently. So it is important not to lose sight of the fact that older adults, no matter where they live, who they are, what race, ethnicity, culture, the fact that they're older is also contributing to inequity. So this is Bergen Newbridge Medical Center's effort, part of their effort. They are going out into the grocery store community and establishing primary care and diagnostic services so that someone can kind of have one-stop shop for groceries as well as some primary care, get screened for hypertension, or really just gather some information about different health conditions with no pressure whatsoever. This matters because they're raising awareness. They're trying to reduce complexity of access to healthcare, and primary care located where people usually go, really promotes access and can lead to prevention, which then reduces the need for the use of the emergency room, the use of the hospital, and so on. At Jewish Home Family, they're partnering with age-friendly communities in Bergen County. And they are bringing education and screening services as well to their community in Bergen. And they are trying to do social determinants of health assessment. And they've learned very quickly that you cannot just plunge into these questions. You have to get to know people, build that rapport and trust, and let them tell you just in a conversation what's happening in their life. And you can pick out what their struggle is. So this is just a picture of their upcoming free health clinics and education. So in the interest of time, I'm going to move on to Kessler because they're doing something rather unique. They're focused on the lymphedema patient who has either not appropriate coverage or no coverage whatsoever to help them access compression garments and other supplies to ease the discomfort that comes with lymphedema. And for those of you who may not be familiar, and I'm not a clinician, my understanding is, fluid gathers in the lymphatic system. It can cause a lot of pain and discomfort. Often comes with cancer diagnosis. And without these supplies and compression garments, it can be really difficult for people to function. So they're working with the National Lymphedema Network to provide these services and supplies to the population free of charge. And then Spring Point Senior Living, they are focusing on their affordable senior housing population. You wouldn't think that people who live in a community that is sponsored by a senior living provider would face disparities or inequities, but they're just like other people living next door. They still struggle with transportation. They still struggle with language barriers. And so they're really working to bring those primary care services through a mobile unit to those affordable senior housing communities. So just in closing, what I'll say is for us as an association, what we're seeing is the interest already in wanting to spread this beyond just these 4 organizations. And even within the 4 organizations, some of which have national reach, they want to take what they've done in New Jersey and start applying it everywhere. So that's very exciting. And we're looking forward to supporting them. I'm the facilitator and the cheerleader. They're the ones doing the hard work. So I'm proud of them and excited to be able to share this with you today.
Trade with you. Thank you both so much. So our 5th and final presentation is from Gretchen Susie and Jeffany O'Garo on reducing health disparities through healthy housing, an approach informed by participatory action research. Gretchen Susie's work is dedicated to the social determinants of health, community wealth building, and participatory action research. She's currently the Assistant Vice President of Community Development at Memona Medical Center. I might have mispronounced that a little bit. Susie previously served as a project director for wellness-based development at the MIT Community Innovations Lab, where she helped form the collaboration that has become BCC, or the Brooklyn Communities Collaborative. She was the director of the Aspen Institute Roundtable on Community Change, developing and implementing racial equity promoting strategies with partners across the US. Her research has focused on the effects of stress on human development, social movements, resident activism, public housing, cross-sector alliances, and methods for dismantling structural racism. She holds a PhD in environmental psychology from the City University of New York. And Jeffany O'Garo is a graduate student at the Columbia University Mailman School of Public Health in the Department of Epidemiology. Since 2018, she has had the opportunity to do multiple internships with the Brooklyn Communities Collaborative, where she is actively engaged in conducting health equity research within underserved neighborhoods in Brooklyn, New York. This experience ignited her deep-rooted passion for the field of public health, and through her work, she has witnessed firsthand the disparities and inequities that exist in accessing healthcare and achieving equitable health outcomes. Inspired by these experiences, she plans to do future work furthering her advocacy efforts for underserved communities that are deprived of the essential resources required to attain equitable health outcomes. Please welcome our next set of speakers.
Good afternoon, everyone. I'll just say our health system is called Maimonides. Yes, it's often people call it Maimonides, even people who work there, but it is Maimonides. And so as Erin said, I'm Gretchen Susie. I'm the Deputy Director of Brooklyn Communities Collaborative. And Jeffany and I have actually been working together since before BCC was born.
Hi, everyone. My name is Jeffany O'Garo. I am a Black woman. I am a little bit shorter than Gretchen, and my attire today is mostly Black. As Aaron mentioned, I just graduated from Columbia University. And over the past 5 years, I've done work with Gretchen doing participatory action research. And that was my driving factor to pursue my master's degree in public health.
And Brooklyn Communities Collaborative is a nonprofit organization leveraging the knowledge of community and the power of anchor institutions to close the racial wealth gap and improve the health of underserved Brooklynites. And we convene and support health, education, labor, community-based organizations, economic development corporations, government, and advocacy groups.
So BCC is built on the vision of longtime Brooklyn community leaders who led a years-long successful struggle to prevent closure of 3 safety net hospitals, and on years of an ongoing cycle of social determinants of health-oriented participatory action research in 14 neighborhoods across Brooklyn, where health inequalities are most evident. Through PAR, BCC priorities are set by community members, and PAR is based on the premises that those directly affected have the most insights into how best to solve the challenges they are facing. Our PAR studies have surveyed more than 4,500 community members, trained more than 200 local high school and graduate community health researchers. The findings varied by neighborhood, but common themes stood out every year. Affordable housing units are increasingly scarce. Economic opportunities are limited, and community health outcomes are consistently worse than the citywide averages.
The PAR research began in 2016 as part of New York State's Medicaid waiver in the neighborhoods of Brownsville and East New York. And keeping with the action of participatory action research, leaders from the community, clergy, the health department, universities, labor, formed what we call the East Brooklyn Call to Action, or the EBC2A, for health and economic justice. And we formed that in April 2019 with a forum that attracted hundreds of community members, many of whom are healthcare workers.
The health disparities that EBC2A Coalition united to confront are long-running and structural. The maps in this slide represent 3 of the most emblematic: heat vulnerability, meal gap, and asthma. Each map shows that these adverse events are concentrated in Central and East Brooklyn. From June 2019 to October 2019, EBC2A members surveyed Brooklyn community members to assess their priority needs. Health and housing ranked first by far. Given these survey results, the preponderance of data, as well as findings from as well as findings from previous PAR studies in 2020, these efforts focused again in Brownsville, East New York, and Bedford-Stuyvesant, where the first PAR was conducted in 2016.
From mold to cracks, gaps, leaks, infestation, leads, and crowding, indoor housing conditions in Bedford-Stuyvesant, Brownsville, and East New York are among the worst in New York City, causing and exacerbating asthma, skin irritations, high levels of stress, among other conditions. And the PAR process would also end up shining a light on the depth of issues around social conditions as well. While many of these social conditions are consequences of underfunding of mental health and scattered site supportive housing in New York City, which was severely exacerbated during the pandemic. And so in this slide, the image on the left shows some plumbing issues caused by some unstable tenants or long-running structural plumbing issues that have gone unmaintained. And that has led to, in the middle, if I could show you a video, you would see that this is water. We have a WhatsApp chat, and tenants send the conditions happening in their apartments. And so this is a video of water streaming down a fuse box and the fuse box hissing. And then the image all the way on the right shows a person sleeping in the mailbox area of the same building.
Speaking more to our participatory action research itself, our main research question was, what are the most effective ways to improve housing conditions, especially those that most affect health in Bedford-Stuyvesant, Brownsville, and East New York? One of our key sub-questions was, what are the most effective methods for addressing unhealthy indoor housing condition, and how can they be amplified?
The PAR research revealed, among much else, a lack of skilled property managers and skilled and certified building trades workers in affordable housing. In the fall of 2021, BCC therefore began collaborating with our local CBO partners and real estate developers to launch a property management and stewardship of the built environment fellowship. And this program trains and places community members as skilled New York State certified property managers and professionals in both forthcoming housing developments and other buildings in central Brooklyn. BCC and our partners developed a curriculum with enhanced content on housing as healthcare, tenant landlord law, and leadership development. The program's pilot phase ran from November 2022 until January 2023. We had 15 participants and 100% completion rate, and employers who are eager to hire the graduates and start apprenticeships and see the program expanded. So these photographs illustrate how the work that was catalyzed by these PARs way back in 2016, but also subsequently these photographs illustrate how that work has developed the necessary community-based workforce and knowledge to change the built environment to directly reduce health disparities, at least in this one building. So the photograph on the left, the photographs on the left are of one of the buildings where work is being implemented. And what you can see there is poorly maintained scaffolding from afar. And in the second photograph, you can see with the view from the front door, the scaffolding and the black screening around it that was very unsightly, allowed for the collection of garbage and also the formation of rats' nests. And the third picture all the way on the right shows the building after the scaffolding was removed. It was there for 5 years. And the changes required multiple levels of activity, amplifying resident voice, having access to those with the knowledge and willingness to pierce the bureaucracy of the New York City Department of Buildings, collecting a strong evidence base, both from traditional and community generated data, and mutually beneficial shared vision of health and goodwill among a continuum of very aligned stakeholders.
So although much more is required if health outcomes are to improve, the physical change communicates to residents that improvement is possible. The landlord with a profit and not a health perspective sees that it is their benefit to cooperate. The leak repair, mold and infestation remediation, elevator repairs, and greater attention to security is in evidence in the buildings where the work is targeted. A part to collect baseline data is being carried out in the remaining months of 2023 to more robustly document how both community building and filling critical workforce needs in building care and maintenance are key to reducing health disparities. Thank you.
Thanks, everyone. Thank you.
Thank you both. And so this concludes our breakout session. I just want to give our presenters another round of applause for all this great work. Thank you again to the speakers, to everyone who joined today, CMS for hosting this conference. I also hope you all have a great rest of your day.